APGO Educational Topic Number 53, Uterine Leiomyoma. Uterine leiomyomata, or fibroids, are proliferations of smooth muscle cells. They are very common, and by the 5th decade of a woman's life, they may be present in 1 out of 4 white women and 1 out of 2 African American women. Fibroids are the most common indication for hysterectomy, accounting for approximately 30% for this operation. The objectives of this video are to cite the prevalence of uterine leiomyoma, to identify symptoms and physical findings in patients with uterine leiomyoma, describe the diagnostic methods to confirm uterine leiomyoma, and finally describe the management options for the treatment of uterine leiomyoma. We classify fibroids into 3 groups based on their anatomic location. Here is the uterus, cervix, and endometrium. The first type of fibroid is an intramural fibroid, which is entirely within the wall of the uterus. The second type of fibroid is a subserosal fibroid, which is located beneath the serosal layer of the uterus. The third type of fibroid is a submucosal fibroid, which is located just beneath the endometrium. This is a photograph of a uterus with multiple intramural fibroids. This next photograph also shows a uterus with multiple fibroids, and the arrow points to a large subserosal fibroid. This last photograph is a hysteroscopic view of the endometrial cavity and shows 3 submucosal fibroids. They are considered benign, hormonally responsive tumors, and estrogen stimulates growth. In the high estrogen state of pregnancy, fibroids can induce rapid growth. When a woman goes through menopause and is in a low estrogen state, there will be cessation of growth and even some atrophy. The important message to remember is that for most women, fibroids are asymptomatic and cause no or minimal problems. When fibroids cause symptoms, the symptoms are usually related to bleeding. The type of bleeding can vary, but the classic presentation of abnormal bleeding related to fibroids is heavy periods. The simplest way of thinking about why fibroids cause heavy periods is to envision the fibroids distorting the endometrial cavity. A submucosal fibroid will obviously be the most likely type of fibroid to distort the endometrial cavity. Intramural fibroids can distort the endometrial cavity if they are of significant size or quantity. Subserosal fibroids are the least likely type of fibroid to cause bleeding problems, again unless they are big enough or if there are enough of them. The second classic symptom of fibroids is pelvic pressure, or the sensation of a pelvic mass. Fibroids can attain a massive size, and here is a photograph of a large subserosal fibroid growing on the posterior wall of the uterus. This second photograph illustrates another example of a uterus that has multiple fibroids of significant size, and we refer to this as a large myomatous uterus. The third classic symptom of fibroids is dysmenorrhea or painful menses. Let's now move to physical examination. You may remember Dr. Palm Cohen from the APGO abnormal uterine bleeding video. Remember that the L of the Palm Cohen abnormal uterine bleeding classification system stands for leiomyoma. Physical examination findings depend on the size and number of the fibroids. If the uterus is large, then it can be palpated abdominally. And since we are obstetrician gynecologists, we often describe the size of the uterus in terms of week size compared to the pregnant uterus.
You have a 20-week sized uterus.
Or we will describe the number of finger breaths beneath the umbilicus.
Your uterus palpates to 2 finger breaths below the umbilicus.
Smaller fibroids, or fibroids that are submucosal or intramural, may not be palpable on physical examination. The diagnosis is made through physical examination and imaging studies. Pelvic ultrasound can help quantify the number and size of the fibroids. Here is an ultrasound with a sagittal view of the uterus. The hyperechoic area is the endometrial cavity, and the arrow points to a small intramural fibroid. A sonohysterogram can better visualize the endometrial cavity. Saline is instilled through the cervix into the endometrial cavity, and this image shows a normal, non-distorted cavity. A sonohysterogram can help to characterize the percent of a fibroid that is in the endometrial cavity in order to determine whether hysteroscopic resection of a fibroid is feasible. Occasionally, an MRI can be useful to better visualize the exact size and location of the fibroids. Let's now move to management options, and remember that most women do not require any treatment, especially if the fibroid is small and found incidentally on imaging study. When bleeding is the main symptom that the patient is experiencing, then medical therapy can be used to try to minimize the abnormal bleeding. This can be estrogen and progesterone, usually with oral contraception. Since fibroids often become symptomatic in women in their 5th decade of life, remember that oral contraception should not be given to women over age 35 with hypertension, who smoke, or who have migraines. Progestins are another option to help temporize bleeding. Prostaglandin synthetase inhibitors such as ibuprofen can decrease the amount of dysmenorrhea and the amount of menstrual flow. And finally, GnRH agonists suppress the HPO axis and thus produce a false menopause, and this can lead to a reduction in fibroid size. This can be used as a temporizing measure in women to boost their red blood cell counts prior to definitive surgery, or short-term in women who are close to getting to menopause. It is a short-term solution since it does cause a false menopause and thus will have the detrimental effect of the hypoestrogen state on bone and cardiovascular health. Uterine artery embolization is a procedure performed by interventional radiologists. A catheter is inserted into the femoral artery to the uterine arteries, which are then embolized with tiny microspheres. This results in fibroid devascularization and involution. There is short and long-term data that supports that uterine artery embolization is a safe and effective management option for fibroids for appropriately selected women who wish to retain their uteri. Let's now move to surgical options. Myomectomy is another option for women who desire to preserve their uteri. The myomectomy can be performed either abdominally, either via a laparoscopy or laparotomy approach. Hysteroscopic myomectomy can be performed if there is a distinct submucosal fibroid. The following video will demonstrate a hysteroscopic myomectomy. You can see the small submucosal fibroid that is being removed with a hysteroscopic instrument. At the completion of the procedure, the endometrial cavity has been restored to normal anatomy. And finally, hysterectomy is definitive therapy for fibroids. Indications should be specific and well documented. It can be performed vaginally or abdominally depending on the size and location of the fibroids. This concludes the APGO video on uterine leiomyoma. We have discussed the prevalence, symptoms, physical exam findings, and diagnostic methods and management options for this common finding in women.